I'm standing on the sidelines when I see an athlete get hit and fall unconscious on the ground. In my ERP, I have my sport-specific procedures reviewed and my team is rehearsed. In my team, I have my call person, charge person, equipment person, control person, and assistants ready. I have my EMS numbers 911 ready on dial, and I have them written down, and I verified reception. I also have my PPE, so I have my gloves, my glasses, and I have my visor. I ensure that it is safe, the play has stopped, and it is safe for me and for the bystanders for me to enter. I approach the athlete from the feet to the head, do not startle. Without walking over, I stabilize the head. Sir, what is your name? Sir, what happened? Sir, open your eyes. He does not respond. I move on to the painful stimuli, tricep pinch. He doesn't respond. I activate my ERP, call 911. We have an unconscious athlete. I move on to the trauma jaw thrust. I open the mouth and I verify that there's nothing obstructing the breathing and that the tongue is not blocking. I verify the breathing for 10 seconds. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. The breathing feels not laborious. It's even on both sides, and the breathing is regular. There's 3 breaths in the 10 seconds. I verify the circulation with my third finger on the carotid. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 10 seconds max. And I can feel the pulse, it's regular. I check for any major bleeds, and that concludes my primary assessment.
So, applying Steri-strips. When to apply Steri-strips is when we have either an incision, which would be a clean cut through the dermis, usually, or a laceration, which is a more jagged cut by some sharp object, or it's also possible that the cut is on a rigid part of the body where the skin was in between, and a blunt force hit that sharp area of the body, such as the elbow, the knee, often. In these situations, the goal is going to be to approximate the edges of the wound and to start from the center and work our way outwards. Of course, in general, ensure it's nice and sterile around. Starting off with, we approximate the edges, starting from the center. We move from one edge to the other, keeping it tight. The following Steri-strip will be from the opposite edge, right next to, from the opposite edge, back on the first side. Third Steri-strip will be from the first edge to the second side.
For a puncture wound, it's a bleeding management scenario. I'm always wearing gloves, making my log style reinforcement at least halfway up, nice and secure so that the object does not have room to move. And then with the 5th gauze, I roll around, keeping everything nice and secure.
we ensure that we don't remove the object ourselves. That's going to be done at the hospital, and that concludes our puncture wound secure. Okay, so for assembling the speed splint, for the purposes of this exam, I don't have one for the leg, but the one for the leg is there's an A flap, B flap, goes over a C flap. Now, let's say we have that. We'd start by adding the padding, ensuring that around the joints, so the knee joint and the ankle joint, there's sufficient padding, and all around the leg, so that the leg doesn't move. So here's sufficient padding for the ankle, sufficient padding for the knee. And then we would also put all of our triangular bandages right under the splint. Have it ready like this for the situation. So for the speed splint, before placing it on the athlete, we ensure that the triangular bandages are tucked in. So tucking them in. And now I'm going to secure the limb. The athlete has a mid-tibial fracture. Since we're just 2 people, I'm going to ask the athlete to lift their leg while I slide the splint. Okay, so we slide it as far as we can, as far as possible. Perfect. Now, first one we secure is the one right directly under the fracture. And we remove all the triangular bandages. As tight as possible. So I ran out of triangular bandages. For this reason, I'm using these elastic bandages, but ordinarily it would all be triangular bandages. So directly over the fracture for this one, second. Third one is the ankle. For the ankle, nice and secure. Make a knot right here. And then final, right over the knee joint, above the patella bone. And I would ask the athlete also to squeeze the cardboard to ensure it's tight when we're tightening. Ensure it's nice and secure when we're tightening. Once this is done, we tuck in the edges of the triangular bandages, the leftovers, as best as we can. We also ensure that it's secure, and if it's not, well, then we can undo and tighten some more. And then once everything is tucked in as much as possible, we do our PMSC. So P is pulse behind the medial malleolus for maximum 10 seconds. Motor, could you please wiggle your toes? They can wiggle their toes. As sensation, can you feel this? Mm-hmm. And then finally cap refill. Perfect. And then we also ensure that from this point on, the athlete doesn't use their own effort to move. So either on a dorsal plank or a stretcher would be best. And that concludes our mid-tibial fracture.